In the dimly lit chambers of medieval Europe, physicians practiced an art that was equal parts mysticism, ancient wisdom, and dangerous guesswork. The medieval doctor, adorned in long robes and often sporting a distinctive pointed hat, carried with him the weight of medical traditions stretching back to antiquity, traditions that, while revered, were fundamentally flawed in ways that would prove catastrophic for countless patients. At the heart of medieval medicine lay the humoral theory, a framework so entrenched in medical thinking that it dominated practice for over 1,000 years. Developed by the Greek physician Galen in the 2nd century and built upon Hippocratic foundations, this theory proposed that the human body contained 4 essential fluids or humors: blood, phlegm, yellow bile, and black bile. Health, according to this belief system, depended entirely on these humors existing in perfect balance. Too much or too little of any humor would trigger disease, with different imbalances causing specific ailments. A physician examining a patient in 1320s Paris would first determine which humor had fallen out of balance. A feverish patient with flushed skin would be diagnosed with an excess of blood, a sanguine imbalance. The logical treatment, bloodletting, of course. Using lancets, scarificators, or the infamous medicinal leeches, physicians would drain substantial quantities of blood from already weakened patients, sometimes extracting up to 4 pints, nearly half the body's total blood volume, in the misguided belief they were restoring humoral harmony. The practical applications of humoral theory extended beyond bloodletting. Physicians prescribed emetics to induce vomiting for those with excess yellow bile, while laxatives and enemas, often containing mercury, antimony, or other toxic substances, were administered to purge black bile. Patients suffering from excess phlegm might be given heating substances or have their skin deliberately blistered with hot irons or caustic chemicals to draw out the offending humor. What made this system particularly dangerous was its internal consistency. When patients worsened after treatment, as they frequently did, physicians rarely questioned their underlying theory. Instead, they concluded that the intervention had been insufficient or that another humor had become unbalanced, leading to even more aggressive treatments. The theoretical framework of medieval medicine was further complicated by the concept of complexion, not referring to skin tone, but to the unique humoral makeup of each individual. Physicians believed that people naturally tended toward different humoral balances based on factors including age, gender, and temperament. Women, for instance, were considered naturally colder and moister than men, making them prone to certain ailments requiring specific interventions. This gendered approach to medicine meant that female patients often received treatments based not on their actual symptoms, but on preconceived notions about their bodily constitution. Religious constraints significantly shaped the development of medical knowledge throughout the Middle Ages. Contrary to popular belief, the Church did not maintain a blanket prohibition on human dissection. By the 13th century, limited dissections were permitted for legal and educational purposes, particularly at emerging medical schools in Bologna, Montpellier, and Paris. However, these dissections were infrequent, ceremonial affairs, often conducted once yearly as formal demonstrations rather than investigative procedures. During these rare anatomical demonstrations, a university professor would sit elevated above the proceedings, reading aloud from Galen's anatomical texts, while a surgeon performed the actual cutting on the cadaver, typically the body of an executed criminal. If the observed anatomy contradicted Galen's descriptions, the discrepancy was typically attributed to the degradation of human bodies since ancient times rather than to errors in the classical texts. This reverence for ancient authority over observable evidence severely hampered anatomical progress. The Church's influence extended beyond dissection policies to shape acceptable treatments. Medicine and religion were deeply intertwined, with illness often viewed as divine punishment or spiritual trial. The line between medical practitioner and religious healer frequently blurred. Monastery infirmaries served as important healthcare centers, with monks compiling and copying medical manuscripts while simultaneously offering prayers alongside herbal remedies. Saints were invoked for specific ailments, Saint Blaise for throat problems, Saint Apollonia for toothaches, and religious relics were applied as therapeutic devices. This religious framework created a medical landscape where spiritual and physical treatments coexisted and sometimes conflicted. Physicians had to navigate complex theological considerations when treating patients. Could a particular treatment interfere with divine will? Might certain symptoms represent demonic influence rather than physical disease? These questions weren't merely philosophical, but had practical implications for treatment choices. The reverence for ancient medical texts formed another cornerstone of medieval medical theory. Physicians relied heavily on a small canon of authoritative works, most notably Avicenna's Canon of Medicine, Galen's numerous treatises, and Dioscorides' De Materia Medica. These texts reached medieval Europe through a circuitous route, often translated from Greek to Syriac to Arabic, and finally to Latin. Each translation introduced errors and cultural reinterpretations, creating a medical literature that was both revered and fundamentally flawed. Avicenna's Canon, completed around 1025, became particularly influential in European medicine. This massive encyclopedia systematized existing medical knowledge into an organized framework that appealed to the scholastic mindset of medieval universities. Medical students memorized large portions of these texts verbatim, often without critical evaluation of their content. The canon contained detailed descriptions of hundreds of diseases and thousands of remedies, many based on complex combinations of herbs, minerals, and animal products. Dioscorides' De Materia Medica, written in the 1st century, provided the foundation for medieval pharmacology. This herbal compendium described approximately 600 medicinal plants, along with mineral and animal products. Medieval copies of this work often featured beautifully illustrated plants, though the illustrations sometimes became so stylized through centuries of copying that they no longer accurately represented the actual plants, leading to dangerous misidentifications. The practical application of these ancient texts created a medical system where theory often trumped observation. When administering treatments, medieval physicians relied more on textual authority than empirical results. If a remedy prescribed by Galen failed to cure a patient, the failure was attributed to improper preparation, poor quality ingredients, or the patient's unique constitution, never to flaws in Galen's fundamental approach. Perhaps one of the most distinctive aspects of medieval medical theory was its integration of astrology and astronomy. These disciplines weren't considered separate from medicine, but essential components of proper medical practice. The positions of celestial bodies were thought to directly influence human health through their effects on the four humors. Medical astrology was taught in universities alongside anatomy and pharmacology. A physician in 1400s Heidelberg would consult astronomical tables before performing almost any significant medical intervention. Bloodletting, in particular, was governed by complex astrological considerations. Charts known as zodiac men mapped different body parts to astrological signs. Aries governed the head, Taurus the neck, and so forth. Bleeding a body part when its corresponding sign was ascendant was considered dangerous. Similarly, the moon's phase was crucial. Waning moons were preferred for procedures that removed substances from the body. This astrological framework extended to diagnosis as well. Physicians cast horoscopes for their patients, believing that the configuration of planets at the moment of illness onset revealed critical information about the disease's nature and prognosis. Medical texts included detailed instructions for interpreting these decumbiture charts. A patient whose illness began when Mars was in Scorpio, for instance, might receive an entirely different diagnosis and treatment than one whose symptoms appeared under Venus in Taurus, regardless of the actual physical manifestations. The intersection of astrology and medicine created a system where timing often took precedence over the nature of the intervention itself. Physicians might delay urgent treatments for days while waiting for favorable celestial alignments. Medical almanacs, popular among both professionals and the public, provided guidance on auspicious days for various procedures. These almanacs were among the earliest printed works following Gutenberg's invention of movable type, indicating their cultural importance. The educational system that produced medieval physicians reinforced these theoretical frameworks. Medical education at the emerging universities of Salerno, Bologna, Paris, and Montpellier emphasized textual knowledge over practical skills. Students spent years studying and debating ancient medical texts in Latin, often with minimal patient contact. A typical medical education involved first completing the liberal arts curriculum, followed by years of medical theory, with practical training coming only at the end, if at all. This text-heavy education created physicians well-versed in theoretical debates, but often ill-equipped for practical challenges. Many could recite Galen's description of fever verbatim, but had limited experience actually treating febrile patients. The emphasis on Latin learning also created a significant divide between university-trained physicians and the surgeons and barber surgeons, who performed most hands-on procedures, but were often illiterate in Latin and therefore excluded from theoretical education. The medieval understanding of disease causation further complicated medical practice. Physicians recognized some environmental factors in disease. Miasmas, or bad air, were widely accepted as disease vectors, particularly after the Black Death of the 1340s. However, they lacked any concept of germ theory or microscopic pathogens. Instead, diseases were attributed to imbalanced humors, celestial influences, or environmental factors like swamp vapors. This theoretical framework led to bizarre preventive measures. During plague outbreaks, physicians recommended carrying sweet-smelling herbs or pomanders to counteract disease-causing miasmas. Some wore bizarre beak-shaped masks filled with aromatic substances when treating plague victims. While some preventive measures inadvertently provided limited protection, like avoiding sick individuals or maintaining cleanliness, the underlying theory remained fundamentally flawed. The intellectual environment of medieval medicine was further characterized by an approach that privileged logical consistency over empirical evidence. Medical debates were conducted using the scholastic method, with its emphasis on reconciling contradictory authorities through careful reasoning. When faced with conflicting information between ancient texts and observed reality, medieval physicians typically sought to resolve the contradiction through ever more complex theoretical explanations, rather than questioning the foundational texts. This approach created a medical system remarkably resistant to change. New observations that contradicted established theory were either ignored or incorporated through increasingly convoluted explanations. The system's internal logic made it nearly impervious to falsification, allowing fundamentally flawed theories to persist for centuries despite mounting evidence of their ineffectiveness. While humoral theory and ancient texts provided the intellectual foundation for medieval medicine, the path to becoming a medical practitioner varied dramatically depending on one's social standing, wealth, and geographic location. The medical landscape of medieval Europe was not populated by a single type of healer, but rather by a complex hierarchy of practitioners with vastly different training, skills, and social status. At the apex of this hierarchy stood the university-trained physicians, products of the emerging medical faculties at institutions like Salerno, Bologna, Paris, and Montpellier. The medical school at Salerno, established in the 9th century and reaching its zenith in the 12th, claimed the distinction of being Europe's first organized medical institution. By the 13th century, universities across Europe had established medical faculties, creating a formalized educational pathway that would shape the profession for centuries. The journey to becoming a university-trained physician was arduous, expensive, and extraordinarily lengthy. A prospective medical student first needed to complete the basic arts curriculum, mastering the trivium and quadrivium. This preliminary education alone might take 6 to 8 years and was conducted entirely in Latin, immediately restricting medical education to those with both the financial means to study for years without income and the social connections to acquire Latin literacy. Once admitted to medical studies, students faced another 5 to 7 years of education before earning the title of doctor. The curriculum at these early medical schools was overwhelmingly theoretical and text-based. At the University of Paris in the 1300s, medical students spent their mornings attending lectures where professors read aloud from Galen, Hippocrates, and Avicenna, often adding their own commentaries. Afternoons were devoted to disputations, formal debates on medical questions conducted according to strict scholastic methods. The content of this education reflected medicine's position as a branch of natural philosophy rather than a practical craft. Students at Bologna in the 14th century studied logic, natural philosophy, astrology, and uroscopy before approaching anything resembling clinical medicine. Anatomy was taught primarily through textual descriptions rather than direct observation, with Galen's often inaccurate human anatomy, based largely on animal dissections, accepted as authoritative. The cost of this education was prohibitive. Beyond tuition fees, students needed to purchase expensive manuscript textbooks, pay for accommodations in university towns, and maintain a lifestyle befitting their status as scholars. Records from Montpellier show that medical students required financial support equivalent to the annual income of a successful merchant. This economic barrier ensured that physicians came almost exclusively from wealthy families, creating a class distinction between university-trained doctors and other practitioners that would persist throughout the medieval period. The culmination of university medical education was a series of examinations that tested the students' knowledge of medical texts rather than clinical skills. At Paris, candidates for the medical doctorate faced three major examinations: the bachelor's examination, the license examination, and the doctoral disputation. The license examination was particularly grueling, lasting several days and requiring the candidate to answer questions from all members of the medical faculty. Success in these examinations certified the candidate's mastery of medical theory, but said little about their ability to treat actual patients. In stark contrast to this text-heavy education stood the training of surgeons and barber surgeons, who learned their craft through apprenticeship rather than formal schooling. A typical surgical apprentice began his training around age 12 to 14, placed with an established surgeon for a period of 5 to 7 years. During this time, the apprentice progressed from observing and assisting with basic tasks to performing increasingly complex procedures under supervision. This practical education produced practitioners with substantial hands-on experience but little theoretical knowledge. While university physicians could explain the humoral theory behind a disease in elegant Latin, surgeons knew how to set broken bones, remove bladder stones, and perform other necessary interventions. They learned anatomy through direct observation during procedures rather than from books, giving them a more accurate, if less systematic, understanding of human structure. The division between physicians and surgeons was reinforced by institutional barriers. In Paris, the Faculty of Medicine actively excluded surgeons, whom they regarded as manual laborers rather than educated professionals. Surgeons responded by forming their own guild, the Confraternity of St. Cosmas and St. Damian, which established its own standards and examinations. This guild required members to know Latin and have some theoretical education, creating a middle tier of practitioners above barber surgeons, but below university physicians. Barber surgeons occupied an even lower rung on the medical hierarchy. Originally charged with cutting hair and trimming beards, these practitioners gradually took on minor surgical procedures like bloodletting, tooth extraction, and lancing boils. Their training was entirely practical, typically consisting of a 3-year apprenticeship focused on manual skills. The red and white striped pole that still symbolizes barbershops originated in this period, representing the bloodied bandages associated with their surgical work. The relationship between these different practitioners was characterized by constant tension and turf wars. University physicians in 14th century London successfully lobbied for regulations preventing surgeons from administering internal medicines, while surgeons in turn sought to prevent barbers from performing complex operations. These conflicts were as much about social status and economic competition as medical philosophy, with each group seeking to protect its privileges and income. For women, formal medical education remained largely inaccessible throughout the medieval period. The universities that trained physicians explicitly excluded female students, effectively barring women from the highest echelons of medical practice. Despite this, women maintained a significant presence in medieval healthcare as midwives, herbalists, and empirics, practitioners who relied on experience rather than formal training. Midwifery represented the most structured female medical role, with its own system of apprenticeship training. A prospective midwife typically trained under an established practitioner for several years, learning to manage normal deliveries and recognize dangerous complications. By the late medieval period, some regions had established formal examinations for midwives. In 15th century Nuremberg, candidates had to be examined by a committee of respected midwives and swear an oath before being licensed to practice. Beyond these formal pathways lay a vast landscape of empirical practitioners with varied training. Bone setters, tooth drawers, itinerant cataract couchers, and herbalists learned their specific skills through family tradition or informal apprenticeship. Many rural communities relied entirely on these empirics and folk healers, having no access to trained physicians or surgeons. Their knowledge was transmitted orally and through practical demonstration rather than written texts. The licensing and regulation of medical practitioners varied dramatically across medieval Europe, creating a patchwork of standards and requirements. In southern Europe, particularly in the Kingdom of Sicily under Frederick II, medical practice was regulated by royal decree as early as 1231. Frederick's Constitutions of Melfi required physicians to study for at least 5 years and pass an examination before practicing, with separate provisions for surgeons. These regulations established one of the first formal licensing systems for medical practitioners. Northern Europe developed medical regulation more slowly and less comprehensively. In England, the Royal College of Physicians wasn't established until 1518, well into the Renaissance. Before this, medical regulation fell to a combination of universities, guilds, and municipal authorities, creating significant regional variation in standards. Many towns had their own examining bodies that assessed practitioners seeking to establish a practice within their walls, but enforcement was often lax. This inconsistent regulation meant that many medieval practitioners operated without formal qualifications or licensing. Rural areas in particular rarely enforced medical regulations, allowing empirics and folk healers to practice freely. Even in regulated cities, unlicensed practitioners abounded. Records from 15th century London show frequent complaints about quacks and charlatans practicing without proper credentials, suggesting that formal regulations were widely circumvented. The Church also played a significant role in medical regulation, particularly regarding clerical practitioners. The Fourth Lateran Council of 1215 prohibited clergy of higher orders from practicing surgery, declaring that the Church abhors bloodshed. This prohibition accelerated the division between medicine and surgery, pushing surgical practice further toward the secular realm while preserving internal medicine as an acceptable clerical pursuit. The actual clinical training received by medieval practitioners was remarkably limited by modern standards. University-trained physicians might complete their entire education without ever conducting a physical examination or treating a patient independently. Medical faculties occasionally organized visits to hospitals where students could observe patients, but hands-on training was minimal. At Montpellier, one of the more practically oriented schools, students were required to accompany established physicians on rounds for 6 months before graduation, their only clinical experience in years of education. This theoretical approach reflected the physician's self-conception as a learned advisor rather than a hands-on healer. The university physician's role was to diagnose the patient's condition through visual inspection, questioning, and examination of bodily excretions, then prescribe appropriate treatments. The actual administration of these treatments, bloodletting, preparing medicines, applying poultices, was delegated to surgeons, barbers, or apothecaries. This division of labor created a medical system where those with the most theoretical knowledge had the least practical experience. A typical physician in 14th century Florence might diagnose a patient's illness through elaborate astrological calculations and humoral theory, then prescribe treatments he had never personally administered or observed. The physical gap between physician and patient was often literal. Some physicians diagnosed solely through messengers carrying flasks of the patient's urine, never seeing the patient at all. For surgeons and barber surgeons, practical skills were paramount, but their understanding of why particular interventions worked remained limited by their exclusion from theoretical education. A surgeon might successfully set a broken bone through experience and mechanical understanding, but explain the healing process through inaccurate humoral concepts. This disconnect between theory and practice hampered the development of more effective treatments. The language barrier between different types of practitioners further complicated medieval healthcare. University education and medical texts were exclusively in Latin, while surgeons and empirics typically worked in vernacular languages. This linguistic divide meant that even when practical healers developed effective techniques, their knowledge rarely influenced university medicine. Conversely, theoretical advances made within universities often failed to reach practitioners working in local languages. The transition from medical education to practice brought medieval healers face to face with the stark limitations of their tools. While physicians might have spent years mastering theoretical texts, the actual implementation of medical care depended on instruments and medicines that were often crude, unhygienic, and dangerous. The medieval practitioner's toolbox reflected the paradoxical nature of medicine in this era, simultaneously sophisticated in its theoretical framework, yet primitive in its practical application. Surgical instruments constituted some of the most visible and intimidating tools of medieval medicine. Crafted primarily by blacksmiths rather than specialized medical instrument makers, these tools were fashioned from iron or steel with handles of wood, bone, or horn. The design of many instruments remained remarkably stable throughout the medieval period, with examples from the 9th century closely resembling those from the 15th. This stagnation reflected both the conservative nature of surgical practice and the limited technological innovations in metallurgy during this period. The trepanning drill exemplified the terrifying reality of medieval neurosurgery. Used to create holes in the skull to relieve pressure, treat epilepsy, or release trapped demons, these hand-powered drills featured a metal bit with sharp teeth that the surgeon would manually rotate against the patient's skull. Early versions lacked safety features, creating significant risk of plunging into the brain once the bone was penetrated. By the 13th century, more sophisticated models incorporated adjustable depth guards, but the procedure remained extraordinarily dangerous. Without anesthesia beyond alcohol or opium preparations, patients endured this procedure fully conscious, restrained by assistants. Amputation saws were another dreaded tool in the medieval surgeon's arsenal. These large, straight-bladed saws resembled common carpentry tools, and indeed were often manufactured by the same craftsmen who produced woodworking implements. The typical amputation saw featured a wooden handle with an iron or steel blade approximately 10 to 12 inches long. Unlike modern surgical saws designed to cut efficiently while minimizing tissue damage, medieval saws had coarse teeth that tore through flesh and bone alike, causing additional trauma and increasing infection risk. The speed of amputation was considered crucial, as surgeons recognized that longer procedures resulted in higher mortality. A skilled surgeon might remove a limb in under 2 minutes, though this haste often came at the cost of precision. The patient, sedated with alcohol, mandrake, or opium but still conscious, would be held down by several strong assistants. After the procedure, the resulting stump was typically cauterized with red-hot irons to stem bleeding, adding further trauma to an already devastating experience. Cauterizing irons represented another category of common surgical tools, used not only for controlling hemorrhage, but as primary treatment for wounds, tumors, and infections. These instruments came in various shapes and sizes, each designed for specific applications. Button-shaped cauteries were applied to larger areas, while pointed instruments allowed for more precise application. Before use, these iron tools were heated in braziers until they glowed red or white hot. The application of such instruments directly to open wounds or exposed tissue caused excruciating pain while creating extensive tissue damage that often resulted in severe scarring and secondary infections. For more delicate procedures, surgeons employed an array of specialized tools. Curved needles threaded with silk, linen, or animal gut were used for suturing wounds. Forceps and extractors, similar in design to modern tweezers but considerably larger and less precise, allowed surgeons to remove foreign objects, bladder stones, or arrow points from wounds. Probes, thin metal rods with rounded tips, were used to explore the depth and direction of wounds, particularly important in arrow or sword injuries, where the internal damage often exceeded the visible external wound. The complete absence of sterilization represented perhaps the most dangerous aspect of medieval surgical practice. Instruments were typically cleaned by wiping with cloth, rinsing with wine or vinegar, or at best, passing through flame, methods that removed visible contamination but left microscopic pathogens intact. Surgeons commonly carried their instruments in leather pouches or wooden boxes where they remained between procedures, accumulating contamination. During surgery, instruments might be placed on unclean surfaces or reused on multiple patients without adequate cleaning, creating ideal conditions for cross-contamination. This lack of sterilization reflected not negligence but the complete absence of germ theory. Medieval practitioners had no concept of microscopic pathogens and attributed wound infections to imbalanced humors, poor air quality, or the patient's constitutional weaknesses. The connection between unclean instruments and post-surgical infections wouldn't be established until the 19th century, leaving medieval patients at the mercy of invisible threats their healers couldn't comprehend. The diagnostic tools of medieval physicians seemed designed more to impress patients than provide accurate information. Elaborate urine flasks, thin glass vessels with narrow necks widening to bulbous bottoms, allowed physicians to examine urine color, clarity, and sediment. These examinations followed complex theoretical frameworks that associated specific urine characteristics with particular humoral imbalances. Charts known as urine wheels illustrated dozens of possible urine colors, each linked to specific conditions. While occasionally useful for identifying diabetes or severe kidney disease, most uroscopy provided little reliable diagnostic information. Astrolabes and astronomical charts, while not strictly medical instruments, formed an essential part of the physician's toolkit. These devices allowed practitioners to calculate the positions of celestial bodies thought to influence health and disease. A physician might refuse to perform a procedure if the stars were deemed inauspicious, regardless of the patient's condition. The astrolabe's complex brass construction and mathematical markings lent an air of scientific authority to what was essentially superstitious practice, reinforcing the physician's status as a learned practitioner of a complex art. For bloodletting, the most common medical intervention of the medieval period, practitioners employed several specialized tools. The simplest was the fleam, a broad-bladed knife used to open veins, typically at the elbow. More complex was the scarificator, a spring-loaded device containing multiple small blades that, when triggered, created several shallow cuts simultaneously. These mechanical devices became increasingly sophisticated over time, with later models featuring adjustable blade depths and exchangeable cutting heads. Medicinal leeches provided a less traumatic method of bloodletting, particularly useful for sensitive areas or when precise amounts of blood needed to be removed. Kept in water-filled jars, these creatures were applied directly to the skin, where they attached and extracted blood until satiated. A single leech could remove approximately 515 ml of blood, and multiple leeches were often applied simultaneously. After use, leeches were sometimes induced to regurgitate and reused on other patients, creating another vector for disease transmission. While surgical tools were intimidating, the medieval pharmacopoeia presented equally significant dangers. Apothecaries and physicians worked with a vast array of substances derived from plant, animal, and mineral sources, creating medicines that ranged from mildly effective to actively harmful. The preparation of these remedies involved complex processes carried out with equipment that would eventually evolve into modern chemical apparatus. Herbal medicines formed the foundation of medieval pharmacy, with hundreds of plants used for medicinal purposes. Many of these botanicals contained genuinely active compounds. Willow bark, rich in salicylic acid, effectively reduced fever and pain. Foxglove, containing cardiac glycosides, could strengthen heart contractions when properly dosed. Ergot fungus, despite its dangerous toxicity, was used to control postpartum hemorrhage due to its uterine contracting properties. The preparation of herbal medicines required extensive knowledge and specialized equipment. Fresh or dried plants were processed through various methods, including infusion, decoction, and maceration. Apothecaries used mortars and pestles of varying sizes to grind materials to specific consistencies. Ceramic alembics, distillation apparatus consisting of a cucurbit, head, and receiver, allowed for the extraction of essential oils and alcoholic compounds from plant materials. The complexity of medieval pharmaceutical preparations is evident in surviving recipe collections. A typical compound medicine might contain dozens of ingredients, each requiring specific processing before combination. The theriac, a famous antidote and cure-all, contained up to 64 ingredients including viper flesh, opium, myrrh, and cinnamon, all combined according to precise formulas. The preparation of theriac was so elaborate that in some cities it became a public ceremony, with physicians overseeing apothecaries as they compounded this prestigious remedy. Animal products featured prominently in medieval medicine, often selected based on sympathetic magic rather than therapeutic effect. Powdered deer antler was prescribed for male virility, while fox lung was used to treat respiratory ailments. More revolting remedies included album graecum, used in throat medicines, and mumia, believed to have healing properties. While most animal-based medicines had little therapeutic value, some, like cod liver oil containing vitamins A and D, provided genuine benefits. The mineral component of the medieval pharmacopoeia presented the greatest dangers to patients. Heavy metals including mercury, lead, antimony, and arsenic were regularly incorporated into medicines, causing acute toxicity and chronic poisoning. Mercury, used to treat syphilis and skin conditions, was applied topically as ointments or taken internally as pills. Lead compounds appeared in cosmetics and wound treatments. Arsenic was prescribed for fevers and skin conditions. These treatments often caused symptoms worse than the original ailment, including kidney failure, neurological damage, and death. The economic aspects of acquiring medicinal ingredients created significant challenges for medieval practitioners. Exotic substances commanded extraordinary prices, reflecting the difficulty and danger of their procurement through extended trade routes. Theriac required ingredients from throughout the known world, including components from India, Africa, and the Middle East. A single dose of high-quality theriac might cost the equivalent of a week's wages for a skilled craftsman, placing it beyond the reach of common people. This high value created persistent problems with adulteration and counterfeit medicines. Saffron, worth its weight in gold and used to treat melancholy and strengthen the heart, was frequently adulterated with safflower or turmeric. Genuine balsam from the Middle East was often replaced with cheaper local resins. Musk, derived from the gland of the male musk deer and used in numerous compound medicines, was routinely diluted or substituted with synthetic alternatives. These substitutions not only reduced therapeutic effectiveness, but sometimes introduced additional toxins. The preparation of medicines involved labor-intensive processes that required specialized equipment and considerable skill. Distillation, perhaps the most sophisticated pharmaceutical technique of the medieval period, used alembics to separate and concentrate volatile compounds from plant materials. Initially introduced to Europe through Arabic medical texts, distillation technology gradually improved throughout the medieval period, allowing for the production of increasingly refined medicinal alcohols and essential oils. Calcination, the heating of substances to high temperatures to create mineral ash or powder, required special furnaces capable of maintaining controlled heat levels. Apothecaries used these techniques to process minerals like zinc, antimony, and mercury into forms believed more suitable for medicinal use. Ironically, these processing methods often increased toxicity by creating more bioavailable compounds, making the refined medicines more dangerous than the raw materials. Fermentation processes were employed to create medicinal alcohols, vinegars, and specific plant preparations. Wooden or ceramic vessels allowed controlled microbial action to transform starting materials into products with different properties. While practitioners lacked understanding of the biological processes involved, they developed empirical knowledge about fermentation conditions and timing that allowed for consistent production of medicines like medicinal wines and vinegars. The equipment used for these processes evolved significantly throughout the medieval period. Early pharmaceutical apparatus was primarily ceramic or glass, with designs adapted from cooking vessels. By the late medieval period, specialized equipment had developed, including water baths for controlled heating, graduated containers for more precise measurement, and improved distillation apparatus capable of producing higher quality distillates. Despite this technological evolution, standardization remained a persistent problem in medieval pharmacy. Without precise measurements or quality controls, the potency and composition of medicines varied dramatically between practitioners and even between batches produced by the same apothecary. A handful of herbs or a sufficient quantity of honey provided inadequate guidance for consistent preparation. This variability meant that patients receiving the same prescription from different apothecaries, or even from the same apothecary at different times, might experience dramatically different effects. The storage of medicines presented additional challenges. Glass and ceramic containers provided the best protection, but their expense meant that many preparations were kept in leather pouches, wooden boxes, or animal bladders that offered minimal protection from contamination or degradation. Liquid preparations frequently spoiled, while dried materials absorbed moisture or became infested with insects. The concept of expiration dates didn't exist, and medicines might be used years after preparation, long after any beneficial properties had deteriorated. The medieval physicians' approach to treatment, firmly rooted in humoral theory, created a medical landscape where causing harm to already suffering patients was not merely acceptable, but considered essential for healing. No practice exemplified this paradox more perfectly than phlebotomy, the deliberate cutting of veins to drain blood from the body. Bloodletting stood as the cornerstone of medieval therapeutics, prescribed for ailments ranging from fever and inflammation to melancholy and plague. The practice of phlebotomy followed elaborate protocols developed over centuries. A physician in 1350s Montpellier would first consider the patient's age, constitution, and the season before determining how much blood to remove and from which location. The body was mapped with specific veins designated for particular conditions: the cephalic vein in the right arm for headaches, the saphenous vein near the ankle for menstrual disorders, the median cubital vein at the elbow for fever. This anatomical targeting reflected the belief that drawing blood from specific locations could extract the corrupted humors causing disease in corresponding body parts. The amount of blood removed during a typical session would horrify modern medical practitioners. For a robust adult male with fever, physicians commonly extracted 16 to 30 ounces, up to 20% of total blood volume, in a single session. More alarming still, repeated bleedings might be performed daily until symptoms improved or the patient became too weak to continue. Medical texts from the period record cases where patients underwent 10 or more consecutive days of bloodletting, losing dangerous amounts of blood cumulatively. This aggressive approach proved particularly devastating for patients already weakened by disease. The body's compensatory mechanisms, increased heart rate, vasoconstriction, and fluid shifts, created temporary improvements that physicians misinterpreted as confirmation of their theory. A feverish patient might indeed feel cooler after significant blood loss, not because the hot humor had been successfully removed, but because the body was entering shock. When patients died following treatment, physicians rarely questioned the practice itself, instead blaming insufficient bleeding or treatment that began too late. For those who could afford it, leeches offered a less traumatic alternative to the lancet. These blood-sucking annelids were collected from ponds and marshes, then stored in special containers in the physician's or apothecary's shop. Applied to the skin, each leech could extract approximately 15 ml of blood before detaching, with multiple leeches used simultaneously to achieve the desired blood loss. The leech's saliva contained natural anticoagulants and vasodilators that prevented clotting and enhanced blood flow, creating a slow, steady extraction that physicians believed was particularly effective for drawing out bad humors from deep tissues. The popularity of leeches reached extraordinary levels in some periods. In 1833, France imported over 40 million leeches for medical use, reflecting the continued dominance of this therapy well into the early modern period. The sustained belief in bloodletting's efficacy despite mounting evidence of harm, illustrates how deeply entrenched humoral theory remained in medical practice throughout the medieval and early modern eras. Cupping represented another common method of drawing blood or harmful vapors from the body. In dry cupping, heated glass cups were placed on the skin, creating suction as they cooled. This drew the skin upward into the cup, breaking capillaries and causing localized bruising. Wet cupping combined this technique with scarification. After removing the cups, the practitioner made small incisions in the raised skin and reapplied the cups to draw out blood. Both methods were believed to extract harmful substances from deeper tissues that couldn't be reached through standard venesection. The medieval physicians' arsenal extended beyond bloodletting to include various purgative treatments designed to expel excess humors through other bodily orifices. The fundamental principle remained consistent. Disease resulted from humoral imbalance, so forcing the body to expel substances would restore equilibrium. This logic gave rise to a range of treatments targeting different excretory pathways, many involving substances that would now be classified as dangerous poisons. Emetics, substances that induce vomiting, were prescribed for conditions believed to stem from excess phlegm or corrupted bile in the stomach. Common emetics included white hellebore, mustard seed, and copper sulfate, all of which triggered violent vomiting by irritating the stomach lining. The plant Ipecacuanha, containing the alkaloid emetine, proved somewhat safer than mineral alternatives but still caused significant distress. Patients might be instructed to consume these substances repeatedly until they produced clear vomit, indicating all corrupted humors had been expelled, a process that often led to dangerous dehydration and electrolyte imbalances. Cathartics or laxatives represented another class of purgatives designed to expel corrupted humors through the intestines. Medieval physicians classified these substances hierarchically based on their strength. Mild laxatives like prunes, figs, and honey were prescribed for children, the elderly, or weakened patients. Moderate purgatives included senna leaves, rhubarb root, and castor oil. For stubborn conditions requiring powerful purging, physicians turned to dangerous compounds containing antimony, mercury, or plant toxins like those found in black hellebore or spurge. Among the most dangerous purgatives was antimony, a metalloid element whose compounds were valued for their dramatic cathartic effects. Antimony potassium tartrate, commonly known as tartar emetic, induced violent vomiting and diarrhea along with sweating and salivation, effects physicians interpreted as the successful expulsion of harmful humors from multiple bodily pathways simultaneously. What they failed to recognize was that these symptoms actually represented antimony poisoning, which damaged the liver, kidneys, and heart while providing no therapeutic benefit. Mercury compounds featured prominently in medieval and early Renaissance pharmacopoeia, particularly for treating skin conditions and, later, syphilis. Administered as pills, ointments, or fumigations, mercury caused profuse salivation, with patients sometimes producing several pints of saliva daily, an effect physicians interpreted as the body purging corrupt humors through the mouth. The reality was far more sinister. Mercury's neurotoxic effects were causing the salivation, while simultaneously damaging the brain, kidneys, and peripheral nerves. The saying, "a night with Venus, a lifetime with Mercury," captured the grim reality that the treatment for syphilis often proved as devastating as the disease itself. Enemas represented yet another approach to purging, using liquid solutions injected into the rectum to evacuate the bowels. The medieval enema apparatus consisted of a bladder or syringe connected to a tube, often made from animal intestines or silver for wealthy patients. The solutions ranged from relatively benign mixtures of warm water with salt or honey to dangerous concoctions containing wine, herbs, and mineral irritants. Physicians prescribed enemas not only for constipation, but for fevers, headaches, and general malaise, believing that fecal matter retained too long would putrefy and poison the body. The frequency and volume of these purgative treatments often exceeded any reasonable therapeutic approach. A physician treating a fever might prescribe daily emetics, followed by cathartics, complemented by bloodletting, a combination that inevitably weakened patients already compromised by illness. Medical texts recommended continuing these treatments until the patient showed signs of improvement or became too debilitated to continue, with little recognition that the debilitation itself was largely iatrogenic, caused by the treatment rather than the disease. Perhaps the most challenging aspect of medieval medicine for both practitioners and patients was pain management. Without modern anesthetics or strong analgesics, medieval healers faced the daunting task of performing necessary procedures on fully conscious patients while having limited means to alleviate their suffering. The approaches they developed ranged from partially effective herbal preparations to psychological techniques that would still be recognizable in modern pain management. Opium stood as the most effective analgesic in the medieval pharmacopoeia. Derived from the seed pods of Papaver somniferum, opium was prepared as a tincture in alcohol, as pills mixed with other ingredients, or as a component in complex preparations like theriac. Physicians recognized opium's effectiveness for severe pain, insomnia, and controlling diarrhea, though they understood its mechanism in terms of cooling the body rather than its actual action on opioid receptors. The risk of addiction was recognized, with medical texts warning against prolonged use, but in an era of limited alternatives, opium remained the standard for severe pain despite its dangers. Henbane provided another important though dangerous option for pain control. Containing the anticholinergic alkaloids hyoscyamine and scopolamine, henbane induced sedation and amnesia while reducing secretions, effects particularly useful during surgery. Medieval surgeons soaked sponges in henbane extracts mixed with other soporific plants like hemlock and opium, then held these soporific sponges over the patient's nose and mouth before painful procedures. While not providing true anesthesia, this approach induced a confused, semi-conscious state where patients experienced pain but often retained limited memory of the procedure. Contrary to popular belief, mandrake played a less significant role in medieval pain management than often portrayed in modern accounts. While the plant contains anticholinergic alkaloids similar to those in henbane, it was relatively rare and expensive in medieval Europe. When available, it was used similarly to henbane, but most surgical texts mention it less frequently than other soporific plants. The mandrake's legendary status, with its human-shaped root supposedly screaming when pulled from the ground, may have contributed to modern exaggeration of its medical importance. Alcohol served as the most widely available analgesic and sedative, used across all social classes for pain management. Before painful procedures, patients might consume large quantities of wine or distilled spirits to dull sensation and reduce anxiety. Surgical texts recommended having the patient drink until visibly intoxicated before attempting procedures like bone setting, tooth extraction, or abscess drainage. While alcohol provided limited pain relief and potentially dangerous side effects, its universal availability made it the default option for most practitioners and patients. Physical restraint remained an essential component of medieval surgical practice, regardless of what analgesic options were employed. Surgical texts described specific techniques for restraining patients during different procedures, with multiple assistants assigned to hold the patient immobile. For amputations, typically 4 strong men were required, one to hold each limb, while another assistant might be responsible for restraining the patient's head or administering wine during the procedure. These restraint techniques recognized the inadequacy of available pain management and the necessity of completing procedures quickly despite the patient's distress. Beyond chemical approaches, medieval practitioners employed various psychological techniques to manage pain. Distraction through prayer, chanting, or conversation features prominently in surgical texts. Religious comfort played a central role, with surgeons invoking saints appropriate to specific procedures, Saint Apollonia for dental work, Saint Agatha for breast surgery. Patients were encouraged to focus on religious imagery or prayers rather than their physical suffering, an approach not entirely different from modern mindfulness techniques for pain management. The speed of surgical intervention became a critical factor in minimizing patient suffering. A skilled medieval surgeon prided himself on completing procedures with maximum efficiency. An amputation might be performed in under 2 minutes, a bladder stone extraction in under 5. This emphasis on speed while partly motivated by compassion, often came at the cost of precision and care, creating additional trauma that modern surgeons would find unacceptable. Nevertheless, in an era of limited analgesia, rapid completion of painful procedures represented one of the few mercies available to patients. Cauterization, the application of red-hot metal instruments to body tissues, served multiple purposes in medieval medicine, functioning simultaneously as a hemostatic technique, a treatment methodology, and a pain management challenge. The primary purpose of cautery was to stop bleeding from wounds or surgical sites, particularly after amputations where uncontrolled hemorrhage posed an immediate threat to life. A surgeon performing a leg amputation in 1400s Bologna would have several cautery irons heating in a brazier nearby, ready to apply directly to bleeding vessels immediately after the limb was removed. Beyond controlling hemorrhage, cauterization was employed as a primary treatment for numerous conditions. Physicians used hot irons to burn away tumors, hemorrhoids, and infected tissue, believing that the heat would both destroy the diseased area and seal in corrupted humors that might otherwise spread. For chronic joint pain, superficial burns were created over the affected area, creating counter-irritation thought to draw disease away from deeper structures. These therapeutic applications of cautery often caused extensive scarring and secondary infections while providing questionable benefit. Perhaps most strangely to modern sensibilities, cauterization was employed preventively based on humoral theory. Medical texts recommended preventive cautery for healthy individuals with excess humors or those exposed to plague. These treatments involved creating deliberate burns at specific body locations, often along the spine or on the extremities, to create pathways for harmful humors to exit the body. While excruciating and dangerous, these procedures were considered valuable health maintenance for those who could afford them. The instruments used for cauterization came in dozens of specialized shapes, each designed for specific applications. Olive-shaped cauteries provided broad surface area for sealing large vessels, while pointed instruments allowed for precise application to smaller structures. Button cauteries with flat circular ends were applied to create deliberate, uniform burns for humor release. The diversity and specialization of these instruments reflect the central role cauterization played in medieval therapeutics despite its obvious brutality. The implementation of these treatments, bloodletting, purging, pain management approaches, and cauterization varied dramatically based on the patient's social status and wealth. For the nobility and wealthy merchants, treatments were modified to minimize discomfort and maximize dignity. Bloodletting might be performed with finely crafted silver lancets rather than iron tools, with blood collected in decorated ceramic basins. Purgatives were compounded with expensive spices to improve taste, and pain management included the finest imported opium rather than crude local alternatives. For common people, particularly in rural areas, treatments were administered with less refinement and consideration. A village barber surgeon might perform bloodletting with the same knife used for multiple purposes, collecting blood in wooden bowls or directly onto the ground. Purgatives consisted of locally available irritant plants administered without taste-improving additives. Pain control might be limited to raw alcohol or nothing at all beyond physical restraint. This two-tiered system of care meant that while all medieval patients suffered from the fundamental limitations of medical knowledge, the poor endured additional burdens from crude implementation. When the Black Death reached the shores of Sicily in October 1347, carried by Genoese trading ships from Caffa in the Crimea, it confronted medieval medical practitioners with a catastrophe beyond their comprehension. Within months, the disease had spread throughout Italy, racing across Europe with devastating speed. By 1352, between one-third and one-half of Europe's population lay dead, victims of a disease against which medieval medicine proved utterly powerless. The medical profession's response to the Black Death revealed the fundamental limitations of medieval medical theory when confronted with epidemic disease. Physicians trained in the finest medical schools of Paris, Montpellier, and Bologna found their extensive theoretical knowledge useless against the plague's onslaught. Their carefully reasoned explanations based on humoral theory and celestial influences provided no effective treatments, while their prescribed preventatives failed to protect even the physicians themselves. The most educated medical minds of the era struggled to explain the plague's origins. The medical faculty at the University of Paris, asked by King Philip VI to determine the cause of the pestilence, produced an authoritative report in 1348 attributing the disease to a triple conjunction of Saturn, Jupiter, and Mars in the sign of Aquarius that had occurred in 1345. This celestial event, they explained, had corrupted the air, creating poisonous miasmas that infected those who breathed them. While astronomically accurate, this explanation offered no practical guidance for treatment or prevention. Other physicians looked to more terrestrial explanations, blaming earthquakes for releasing poisonous vapors from the Earth's interior or pointing to unusual weather patterns that had supposedly corrupted the air. The influential physician Gentile de Foligno suggested that the disease originated from putrid matters in the atmosphere, while others blamed the poisoning of wells by marginalized groups, particularly Jews, a theory that led to horrific persecutions across Europe. The symptoms of plague baffled medieval practitioners. The bubonic form, characterized by painful swellings in the lymph nodes of the groin, neck, and armpits, seemed to confirm humoral theories about the collection of corrupt black bile. However, the pneumonic form, which attacked the lungs and spread directly from person to person through coughing, and the septicemic form, which caused rapid death with few external symptoms, defied easy categorization within existing medical frameworks. The speed with which plague killed particularly undermined traditional medical approaches. Patients with pneumonic plague often died within 2 to 3 days of symptom onset, while those with septicemic plague sometimes perished within hours. This rapid progression left little time for the elaborate treatments favored by university physicians, which typically required days or weeks to rebalance the humors. By the time a physician had prepared complex theoriac or calculated the appropriate astrological moment for intervention, the patient was often already dead. Preventative measures recommended by physicians reflected both the miasma theory of disease transmission and the social realities of medieval Europe. Since corrupted air was considered the primary vector, physicians advised sealing windows, burning aromatic woods like juniper and ash, and sprinkling vinegar or rose water to purify indoor spaces. The wealthy were advised to flee to country estates away from crowded cities, while those who remained in affected areas were instructed to carry pomanders, perforated balls filled with ambergris, musk, and herbs, to smell when moving through public spaces. These aromatic preventatives evolved into one of the most iconic images of plague medicine, the beaked plague doctor. Though most associated with the 17th century, early versions appeared during the Black Death. The distinctive costume featured a long wax coat and a mask with a bird-like beak filled with herbs, spices, and aromatic compounds. These substances, including dried flowers, herbs, spices, camphor, and ambergris, were believed to purify the air before it reached the physician's lungs. While striking in appearance, these masks provided no actual protection against Yersinia pestis, the bacterium causing plague, which was transmitted primarily by flea bites or respiratory droplets rather than miasmatic air. Dietary recommendations formed another key component of plague prevention. Physicians advised avoiding foods thought to produce putrefaction in the body, particularly fruits, fish, and most vegetables. Instead, they recommended a diet of bread, well-cooked meat, and wine mixed with bitter herbs. Garlic received particular praise for its supposed protective properties, with some physicians recommending consuming several cloves daily during plague outbreaks. While excessive for most palates, this advice had a limited scientific basis. Garlic does have mild antimicrobial properties, though hardly sufficient to prevent plague infection. For those already infected, medieval medicine offered treatments that ranged from ineffective to actively harmful. The standard approach followed humoral principles. Since plague was associated with excess black bile, treatments focused on expelling this humor through multiple pathways. Bloodletting stood as the primary intervention, with physicians recommending the removal of substantial quantities of blood, often from sites near the buboes. This practice further weakened already compromised patients, likely increasing mortality rather than reducing it. The lancing of plague buboes represented another common but dangerous intervention. Physicians and surgeons would cut open the swollen lymph nodes, sometimes applying cupping devices to draw out the poisonous matter within. While modern medicine does sometimes drain buboes under sterile conditions with antibiotic support, the medieval practice, performed without antisepsis or antibiotics, often introduced secondary infections that hastened death. Some practitioners applied caustic substances to buboes, creating chemical burns intended to draw out the poison, but actually causing additional tissue damage. Theriac, the complex pharmaceutical preparation containing dozens of ingredients including opium and viper flesh, was considered the premier plague treatment among those who could afford it. Physicians prescribed theriac both preventatively and as treatment, with elaborate instructions for its consumption based on the patient's age, constitution, and the phase of the moon. While the opium content may have provided some symptomatic relief, theriac offered no effective action against the plague bacterium itself. The application of live animals to buboes stands among the strangest plague treatments. Physicians recommended placing freshly killed and split pigeons, chickens, or puppies against the swollen lymph nodes, believing these would draw out the poison from the patient into the animal's body. A variation involved applying live toads to buboes until the animals died, supposedly from absorbing the toxic matter. These practices, while scientifically baseless, reflected desperate attempts to transfer the disease from human to animal and illustrated how traditional medical theory failed to provide effective responses to epidemic disease. The professional consequences for physicians during plague outbreaks created profound ethical dilemmas. Many faced the stark choice between fleeing affected areas, abandoning their patients but preserving their own lives, or remaining to provide care despite the enormous personal risk. Medical ethics of the period generally emphasized the physician's duty to treat the sick, with influential medical oaths requiring practitioners to place patient welfare above personal safety. However, the reality of plague's deadliness led many to choose self-preservation. The flight of physicians from plague-stricken areas became so common that civic authorities across Europe implemented extraordinary measures to maintain medical services. In Venice, Milan, and other Italian cities, municipal governments offered substantial salary increases to physicians who agreed to remain during outbreaks. These plague doctors received guaranteed income, tax exemptions, and sometimes citizenship rights in exchange for their dangerous service. Despite these incentives, cities frequently struggled to retain medical practitioners, with records showing repeated salary increases as epidemics intensified and more physicians fled. For those physicians who remained, the plague presented not only physical danger, but profound intellectual and spiritual challenges. The complete failure of traditional treatments forced practitioners to confront the limitations of their medical system. Some responded by doubling down on established theories, attributing treatment failures to improper application or insufficient dosages, rather than questioning the underlying principles. Others began cautiously suggesting modifications to traditional approaches, noting which interventions seemed to help patients and which appeared to hasten death. The most significant professional consequence for physicians who remained in plague-stricken areas was the damage to their reputation and authority. As death tolls mounted despite their interventions, public trust in learned medicine deteriorated. Chronicles from the period record growing skepticism toward university-trained physicians, with some communities turning instead to empirics, folk healers, or religious interventions. A common sentiment expressed in accounts from the time suggested that physicians are useless, for nearly all who are attended by them die. This loss of public confidence created financial hardship for many practitioners. While plague doctors employed by municipalities received guaranteed salaries, independent physicians often saw their practices collapse as potential patients either died, fled, or lost faith in medical treatments. Records from Florence during the 1348 outbreak show that several previously prosperous physicians faced financial ruin as their patient base disappeared, and survivors became increasingly unwilling to pay for ineffective treatments. The social consequences for physicians who failed to cure plague victims could be severe. In extreme cases, physicians faced violence from desperate families or communities seeking scapegoats for the continuing deaths. Municipal records from across Europe document incidents where physicians were attacked by mobs, driven from towns, or subjected to legal proceedings for alleged malpractice or fraud. The charge that physicians were deliberately prolonging the epidemic for financial gain appeared repeatedly, reflecting the public's frustration with medicine's inability to stem the disaster. More commonly, physicians faced less violent but still significant social penalties, including loss of status, public ridicule, and exclusion from civic positions previously open to respected medical practitioners. The plague's devastating impact on medical credibility is reflected in the literature and art of the period, which increasingly portrayed physicians as greedy, ineffectual figures worthy of mockery rather than respect. The iconic image of the plague doctor eventually evolved from a symbol of learning and courage to one associated with death and futility. The ethical dilemmas facing physicians during plague outbreaks extended beyond the question of flight. Those who remained confronted difficult decisions about which patients to treat, how to allocate limited time and resources, and whether to employ unproven or dangerous remedies when conventional approaches failed. Medical writings from the period reveal practitioners struggling with these questions, attempting to balance their commitment to established medical principles against growing evidence of their ineffectiveness. The question of whether to attend plague victims from different social classes created particular ethical challenges. While medical ethics theoretically required treating all patients, practical considerations often led physicians to prioritize wealthy or powerful patients who could offer greater compensation and protection. Municipal plague doctors were typically required to treat all citizens regardless of status, but private practitioners faced no such obligation. Records show that the poor and marginalized received significantly less medical attention during outbreaks, relying instead on charitable institutions or folk remedies. The plague's impact extended beyond individual practitioners to shape the broader development of medicine. The obvious failure of traditional Galenic approaches during successive plague outbreaks gradually undermined confidence in ancient medical authorities, creating openings for new approaches. While this shift occurred slowly, Galenic medicine remained dominant well into the 17th century. The plague experience planted seeds of doubt that would eventually contribute to medicine's scientific transformation. More immediately, the plague crisis spurred the development of public health measures that would have lasting significance. Italian city-states pioneered quarantine practices, establishing isolation facilities for suspected plague carriers and requiring ships to remain anchored offshore for 40 days before crews could disembark. These measures, while based on miasmatic rather than germ theory, nonetheless represented important steps toward population-level health interventions. The Black Death and subsequent plague outbreaks also accelerated the development of dedicated epidemic hospitals, or pest houses, separate from general hospitals. These facilities, specifically designed for isolating and treating plague victims, represented early examples of disease-specific medical institutions. While treatment within these facilities remained ineffective, their establishment reflected growing recognition that epidemic disease required specialized approaches beyond traditional individual care. For individual practitioners, the plague experience forced painful reconsiderations of medical identity and purpose. Physicians trained to believe in their ability to understand and treat disease according to rational principles confronted a catastrophe that defied their explanatory frameworks and therapeutic approaches. This cognitive dissonance appears repeatedly in medical writings from plague periods, as practitioners struggled to reconcile their theoretical knowledge with observed reality. Some physicians responded to this crisis by emphasizing their role as comfort providers rather than curers. When cure proved impossible, they focused on alleviating suffering, managing symptoms, and providing psychological support to dying patients and their families. This shift represented an important adaptation of the physician's self-conception, acknowledging the limits of medical intervention while maintaining professional purpose in the face of overwhelming mortality. In the shadowy realm of medieval medicine, few procedures inspired as much dread as lithotomy, the surgical removal of bladder stones. These calcified masses, formed from mineral deposits in the urinary tract, caused excruciating pain that drove sufferers to seek relief even through the most terrifying operations. For the medieval patient writhing in agony from a bladder stone, the prospect of surgery without anesthesia represented a desperate gamble, trading certain suffering for potential relief with significant risk of death. The procedure itself, developed in ancient times and largely unchanged through the medieval period, was breathtakingly brutal. A patient in 1400s Paris would first be positioned on a table with legs spread and elevated, restrained by strong assistants. The surgeon would insert a metal sound through the urethra to confirm the stone's presence, then make a perineal incision between scrotum and anus. Working by touch rather than sight, the surgeon would push the stone toward the incision using fingers inserted into the patient's rectum, then extract it using specialized forceps or scoops. Throughout this agonizing process, the patient remained fully conscious, experiencing every cut, tear, and manipulation. Pain management consisted primarily of strong wine or opium preparations that dulled awareness without eliminating suffering. The patient's screams were considered an unavoidable aspect of the procedure, with some surgical texts advising practitioners to work in locations where these cries wouldn't disturb neighbors or passing citizens. The dangers of lithotomy extended far beyond pain. Without antiseptic techniques, infection rates were extraordinarily high. Surgeons operated in everyday clothing, often wearing aprons stained with blood and pus from previous procedures. Instruments were cleaned minimally between uses, typically wiped with cloth or rinsed with wine rather than properly sterilized. The perineal incision opened a pathway for bacteria to enter the bloodstream, frequently leading to overwhelming infection and death. Hemorrhage presented another lethal complication. The perineal region contains numerous blood vessels that, when severed, could cause rapid exsanguination. Medieval surgeons lacked effective methods to control deep bleeding, relying primarily on pressure, packing with cloth, or cauterization of visible vessels. When bleeding occurred deep in the wound beyond direct observation, surgeons had few options beyond packing the wound and hoping for spontaneous clotting. Damage to surrounding structures further complicated recovery. The bladder, rectum, urethra, and reproductive structures could all be injured during the blind, probing characteristic of medieval lithotomy. Such injuries often resulted in permanent incontinence, rectal vesicle fistulas, or sterility. For those who survived the immediate procedure, these complications often led to lifetime disability and social isolation. Despite these dangers, certain practitioners developed remarkable skill in this difficult procedure. Itinerant stone cutters traveled between towns, specializing exclusively in lithotomy. The most famous, Franco di Teotonico, reportedly performed thousands of operations across southern Europe in the early 1500s with mortality rates that, while still shocking by modern standards, were considerably lower than those of general practitioners attempting the same procedure. These specialists developed techniques refined through experience rather than formal education, often keeping their methods secret to maintain their competitive advantage. The medieval approach to another dreaded procedure, amputation, reflected similarly limited options for patients facing life-threatening conditions. For the farmer whose leg had been crushed by a cart, the soldier with a limb shattered by a crossbow bolt, or the villager suffering from spreading gangrene, amputation offered the only hope of survival despite its horrific nature. Medieval surgeons approached amputation with a focus on speed above all else. A skilled practitioner could remove a limb in under 2 minutes, minimizing the duration of the patient's agony and reducing blood loss. The patient, having consumed wine or opium preparations but still conscious, would be held down by several strong assistants while the surgeon worked with terrifying efficiency. The procedure began with application of a tourniquet, typically a tight band above the planned cut site, sometimes with a stick twisted into the band to increase pressure. The surgeon would then use a specialized amputation knife to cut quickly through skin and muscle down to the bone in a circular motion. A retractor would pull back the soft tissue, exposing the bone to be sawed through with a serrated bone saw. Once the limb was removed, the surgeon faced the critical challenge of controlling hemorrhage. Cauterization served as the primary method for stopping bleeding from the amputation stump. Surgeons applied red-hot irons directly to the exposed blood vessels, literally cooking the tissue to seal the vessels. The sizzling sound and smell of burning flesh added further horror to an already traumatic procedure. While effective at stopping immediate hemorrhage, cauterization created extensive tissue damage that increased infection risk and prolonged healing time. Alternative methods for controlling bleeding included the application of styptics, substances that promoted blood clotting or constricted blood vessels. Preparations containing alum, copper sulfate, or iron compounds were applied directly to bleeding surfaces. Some surgeons attempted to tie off larger blood vessels using silk or linen threads, an early form of vessel ligation that would eventually become standard practice. However, without fine suture materials or precise instruments, these ligatures often failed or caused additional tissue damage. Post-amputation wound management presented further challenges. Some surgeons left amputation stumps open to drain, while others attempted primary closure using large sutures. Both approaches carried significant risks. Open wounds were vulnerable to contamination, while closed wounds often developed abscesses from trapped infection. Dressings typically consisted of cloth soaked in wine, vinegar, or herbal preparations thought to prevent corruption of the tissues. The psychological impact of amputation in medieval society extended beyond the trauma of the procedure itself. In an agricultural society where physical labor determined survival, the loss of a limb often meant economic devastation. Few prosthetic options existed beyond simple wooden pegs for leg amputees or hooks for those who had lost hands. These crude devices provided minimal functionality and marked the wearer as disabled, often leading to social marginalization. Perhaps even more disturbing to modern sensibilities was the practice of trepanation, the deliberate creation of holes in the skull to treat various conditions. This procedure, with origins dating to prehistoric times, remained a standard intervention for head injuries, epilepsy, severe headaches, and mental disorders throughout the medieval period. The trepanation procedure varied in sophistication depending on the practitioner's training and available tools. The most basic approach involved a simple chisel and hammer, with the surgeon carefully chipping away at the skull until penetrating the bone. More advanced practitioners used specialized trepanation drills with circular cutting edges that could remove a disc of bone more precisely. The most sophisticated tool, the trephine, incorporated a center pin to prevent slippage and a depth guard to avoid plunging into the brain once the bone was penetrated. Patients undergoing trepanation experienced the procedure fully conscious or with minimal sedation from alcohol or opium preparations. The scalp was first incised and pulled back to expose the skull. Then the trepanation instrument was applied with sufficient force to gradually penetrate the bone. Once the skull was breached, the surgeon carefully removed bone fragments, sometimes deliberately leaving the hole open to allow noxious vapors to escape from around the brain. Surprisingly, archaeological evidence suggests that many trepanation patients survived the procedure. Skulls showing healed bone growth around trepanation holes indicate that individuals lived months or years after surgery. This survival rate likely reflects the skull's good blood supply, which helps resist infection, and the fact that the brain itself wasn't directly manipulated during most trepanations. Nevertheless, complications including hemorrhage, infection, and brain damage remained common, with many patients suffering seizures, paralysis, or cognitive impairments following the procedure. The indications for trepanation reveal much about medieval understanding of neurological and psychological conditions. For head injuries with depressed skull fractures, trepanation served a legitimate purpose similar to modern craniotomy, relieving pressure on the brain and removing bone fragments. However, surgeons also employed trepanation for epilepsy, melancholy, and madness, believing these conditions resulted from trapped vapors or pressure within the skull that could be released through the created opening. The medieval surgeon's approach to wound closure demonstrated both ingenuity and the severe limitations of pre-modern medicine. For the knight wounded in battle or the peasant injured during agricultural work, the method of wound closure could determine not just cosmetic outcome, but survival itself. Suturing represented the most sophisticated approach to wound closure, though medieval techniques bore little resemblance to modern surgical practice. Surgeons used needles made from bone, bronze, or iron, much thicker and less refined than modern surgical needles. Suture material consisted of linen or hemp thread, animal hair, or animal intestine processed into catgut. These materials were neither sterile nor consistent in quality, introducing additional infection risk and tissue irritation. The techniques for placing these sutures varied by wound type and location. For simple skin lacerations, surgeons typically used interrupted sutures placed at intervals along the wound. Deeper wounds might be closed in layers, with gut sutures on internal structures and stronger linen sutures on the skin surface. Facial wounds received particular attention, with finer sutures placed closer together to minimize scarring on visible areas, and early recognition of cosmetic considerations in surgery. Perhaps most dangerous was the medieval approach to penetrating wounds, particularly those inflicted by weapons. The introduction of gunpowder weapons in later medieval Europe created particularly challenging injuries, deep, contaminated wounds with extensive tissue damage. The standard treatment for gunshot wounds after the 1500s involved pouring boiling oil directly into the wound, a practice popularized by the influential surgeon Ambroise Paré. This horrific treatment stemmed from the belief that gunpowder itself was poisonous and needed to be neutralized by heat. The patient, already suffering from a serious wound, endured the agony of having boiling oil poured directly into their injury. Beyond the excruciating pain, this practice caused extensive tissue damage that delayed healing and increased infection risk. Paré himself eventually abandoned this approach after observing better outcomes in patients treated with a gentler digestive ointment when he ran out of oil during a battle. Cauterization served as another common method for wound closure, particularly for ragged wounds not amenable to suturing or injuries with significant bleeding. Surgeons applied red-hot irons directly to the wound edges, literally burning the tissue to seal it and stop hemorrhage. While effective at controlling immediate bleeding, this approach created extensive tissue damage, increased infection risk, and resulted in significant scarring and contractures that often limited function. For large wounds where tissue loss prevented direct closure, medieval surgeons showed surprising creativity. Some attempted skin flaps, cutting and rotating adjacent skin to cover defects. Others packed wounds with various materials to prevent contamination while allowing healing by secondary intention. These packing materials included linen soaked in wine or vinegar, herbal preparations believed to prevent corruption, or even processed sponges that expanded to fill wound cavities. The medieval surgeon's understanding of wound healing remained firmly rooted in humoral theory rather than cellular biology. Wound drainage was interpreted as the expulsion of corrupt humors rather than the body's inflammatory response to injury or infection. Pus formation was not recognized as problematic, but actively encouraged as laudable pus, considered a necessary stage in proper healing. This misunderstanding led surgeons to deliberately irritate wounds to promote pus formation, inadvertently increasing infection severity and delaying recovery. The challenges of medieval surgery extended beyond technical limitations to include environmental factors that would horrify modern medical professionals. Operations typically took place in the surgeon's home, the patient's residence, or on battlefields, all settings lacking basic sanitation. Surgeons operated in ordinary clothing, perhaps with an apron to protect from blood splatter, but without gloves, masks, or other protective equipment. Hand-washing before procedures was ritual rather than hygienic, often consisting of rinsing with plain water as a symbolic cleansing. Lighting for surgical procedures depended on daylight supplemented by candles or oil lamps, creating suboptimal visibility for delicate work. Surgeons operated without magnification, relying on naked eye visualization even for procedures requiring precision. These conditions particularly complicated procedures like cataract couching, the displacement of opacified lenses to restore limited vision, where success depended on minute manipulations performed essentially blind. as medieval medicine developed within university settings across Europe, a profound shift occurred in women's health care. The female body, once primarily tended by experienced women healers, increasingly became subject to male medical authority. This transition represented not merely a change in who provided care, but a fundamental restructuring of how female anatomy, physiology, and diseases were understood and treated. The marginalization of female healers accelerated in the 13th and 14th centuries as universities established their monopoly on medical knowledge. These institutions, exclusively male spaces, systematically excluded women from formal medical education. In Paris, the emerging medical faculty issued decrees as early as 1271 prohibiting women from practicing medicine, regardless of their practical experience or community standing. Similar restrictions appeared across Europe, with penalties ranging from fines to imprisonment for women who continued to practice outside narrowly defined acceptable roles. Midwifery initially remained a protected female domain, as male physicians considered childbirth beneath their dignity and unsuitable for their involvement. A typical birth in 1300s England would be attended by a midwife, assisted by several female neighbors or relatives, creating an all-female environment where practical knowledge passed from experienced practitioners to younger women through direct observation and participation. This female-centered approach emphasized supportive care rather than intervention, with midwives primarily monitoring labor progress, providing emotional support, and assisting only when necessary. The practical knowledge of these midwives was considerable. Records from 15th century Germany show that skilled midwives could determine fetal position through external palpation, recognize signs of complications, and perform version maneuvers to turn breech presentations. They possessed extensive knowledge of herbs that could ease pain, strengthen contractions, or reduce bleeding. Their success rates, while difficult to determine precisely from existing records, appear comparable to or better than those achieved by early male practitioners who later entered the field. Yet this female domain faced increasing encroachment as university-trained male physicians began claiming authority over reproductive medicine. By the late 15th century, male barber surgeons and physicians began attending difficult births, initially called only for emergencies, but gradually asserting greater control over normal deliveries as well. This transition was justified through claims of superior theoretical knowledge, despite most male practitioners having never observed normal childbirth before attempting to manage it. The tools developed by these male practitioners reflected their interventionist approach. Obstetrical forceps, invented by the Chamberlain family in the early 17th century, but with predecessors in the medieval period, allowed operators to extract fetuses mechanically. While occasionally life-saving, these instruments caused significant trauma when used unnecessarily or improperly. Unlike midwives who typically supported normal physiological processes, male practitioners more readily employed these mechanical interventions, often with devastating consequences. Perhaps the most disturbing obstetrical procedure was embryotomy, the dismemberment of a fetus to facilitate extraction when normal delivery seemed impossible. When confronted with obstructed labor, medieval surgeons employed specialized hooks, knives, and scissors to systematically dismember the fetus inside the womb. The operator would first perforate the skull to collapse it, then use hooks to extract the head. The body would then be dismembered and removed piece by piece. This horrific procedure was performed on the conscious mother, whose screams and struggles were controlled by assistants holding her down. Embryotomy, while ghastly, reflected the limited options available when labor became dangerously obstructed. Without alternative surgical delivery methods or effective ways to induce labor, practitioners faced impossible choices between sacrificing the child to save the mother or losing both. The procedure's frequency in medical texts suggests it was performed with some regularity, particularly in cases of severe pelvic deformity from childhood rickets, or when fetuses presented in positions making normal delivery impossible. Caesarean section existed in medieval medicine, but almost exclusively as a post-mortem procedure. When a pregnant woman died, surgeons might attempt to extract the fetus quickly in hopes of baptizing it before death, or rarely, finding it still alive. The operation on living women, while occasionally described in texts, was almost invariably fatal due to blood loss and infection. Without anesthesia, effective hemorrhage control, or antisepsis, a woman undergoing cesarean section in the medieval period had virtually no chance of survival. The first documented cesarean section on a living woman with both mother and child surviving dates to 1500, performed by Jacob Neuffer, a Swiss pig gelder who operated on his wife after days of obstructed labor, had failed to produce the child despite the attendance of numerous midwives. This extraordinary case remained an anomaly rather than the beginning of a surgical trend, as the procedure remained almost universally fatal to mothers until the 19th century. The misunderstanding of female anatomy and physiology underpinned many dangerous practices in medieval gynecology. Medical texts from the period reveal a profound ignorance of female reproductive structures, often based on extrapolations from male anatomy rather than direct observation. The influential 2nd century physician Galen had proposed that female genitals were essentially inverted male organs, the uterus corresponding to the scrotum, the ovaries to testes, and the vagina to an internalized penis. This fundamentally flawed understanding persisted throughout the medieval period, shaping treatments that often caused more harm than good. The concept of the wandering womb exemplified these misunderstandings. Medieval physicians, following ancient Greek precedents, believed the uterus could physically move around the body, causing symptoms by pressing on other organs. This supposed movement explained diverse symptoms, including difficulty breathing, fainting, anxiety, and chronic pain. The standard treatment involved attempting to lure the womb back to its proper position through aromatic substances, foul-smelling materials placed near the nose to repel the womb downward, and pleasant scents placed near the vagina to attract it to its proper place. This belief in uterine movement contributed to the diagnosis of suffocation of the womb, the medieval precursor to what would later be called hysteria. Physicians attributed a wide range of symptoms to this condition, including difficulty breathing, anxiety, fainting spells, and convulsions. The underlying theory proposed that the wandering uterus had risen to compress the diaphragm and lungs, causing respiratory distress and subsequent symptoms. Treatments for this condition ranged from relatively benign aromatic therapies to more invasive interventions. Some physicians prescribed marriage and regular sexual activity as treatment, believing that pregnancy would anchor the womb in its proper position. For unmarried women or widows, manual stimulation to induce hysterical paroxysm was sometimes performed by midwives or physicians as a medical treatment. By the late medieval period, mechanical devices had been developed to assist with this therapy, representing early predecessors to modern vibrators. More dangerous treatments included fumigations, where herbs were burned beneath a seated patient so the smoke would enter the vagina and correct the womb's position. These fumigations sometimes used toxic substances that caused chemical burns to delicate tissues. Pessaries, materials inserted into the vagina, contained mixtures of herbs, oils, and sometimes caustic substances that frequently caused inflammation and injury rather than therapeutic benefit. Female practitioners who used traditional herbal remedies found themselves increasingly vulnerable to accusations of witchcraft, particularly as male-dominated medicine solidified its institutional power. The line between accepted medical practice and alleged witchcraft often depended more on the practitioner's gender and social standing than on the actual treatments employed. A female healer using herbal preparations might be accused of witchcraft for the same remedies a university-trained physician could prescribe without suspicion. This vulnerability intensified when treatments failed or patients deteriorated. While male physicians could attribute treatment failures to the severity of the disease, the patient's constitution, or divine will, female practitioners faced accusations of malicious intent. Court records from 15th century Germany show numerous cases where midwives and female healers faced witchcraft charges following unsuccessful treatments or complicated births resulting in maternal or infant death. The herbs traditionally used by female practitioners further heightened their vulnerability. Plants with effects on the reproductive system, particularly those that could induce abortion or affect fertility, were especially associated with witchcraft allegations. Ergot, Savin, Pennyroyal, and Rue all appeared in both midwives' pharmacopoeia and witchcraft trials. Knowledge of these plants' effects represented essential medical information for women's healthcare providers, but could be reframed as evidence of malevolent magic when authorities sought to restrict female healing practices. The social and economic aspects of this transition cannot be overlooked. As university-educated male practitioners displaced female healers, they also captured the economic benefits previously distributed among women practitioners. Midwifery fees, payments for treating women's complaints, and compensation for providing contraceptive or fertility advice represented significant income sources for women with few other professional opportunities. The restriction of these practices to licensed male practitioners transferred this economic activity from women to men, contributing to the financial marginalization of women. Municipal regulations increasingly restricted midwives' autonomy while placing them under male supervision. By the 15th century, many European cities required midwives to be licensed, with examinations often conducted by male physicians with little practical knowledge of childbirth. These regulations typically prohibited midwives from using surgical instruments, administering internal medicines, or treating conditions beyond normal pregnancy and delivery. Violations could result in fines, loss of license, or even criminal charges. Despite these restrictions, midwives maintained significant authority within their narrowing domain. In many regions, they served important legal functions, testifying in cases involving pregnancy, virginity, or suspected infanticide. Their testimony could determine paternity cases, verify pregnancy in criminal proceedings, and establish whether a newborn had been born alive in infanticide investigations. This legal role reflected their recognized expertise in female physiology, even as their broader healing role diminished. The practical consequences of this transition for women's health care were largely negative. As female practitioners with generations of empirical knowledge were replaced by male physicians guided by flawed theoretical frameworks, treatments often became more invasive and less effective. The supportive care model of traditional midwifery gave way to interventionist approaches that frequently caused additional trauma and complications. Beyond physical treatments, the psychological aspects of women's healthcare suffered during this transition. The all-female environment of traditional childbirth and gynecological care had provided emotional support and understanding based on shared experience. Male practitioners, separated by gender, social status, and theoretical orientation, often approached female patients with clinical detachment or barely disguised disdain. Medical texts from the period reveal deeply misogynistic attitudes, with female physiology described as inherently defective and women characterized as less rational and more prone to imaginary ailments than men. The language used to describe female anatomy and physiology in medieval medical texts reveals the profound gender biases shaping women's health care. Female reproductive organs were consistently described in terms of their deviation from the male norm, rather than as structures with their own proper form and function. The uterus was characterized as an imperfect organ prone to dysfunction, while menstruation was described as the necessary expulsion of impurities resulting from women's colder, moister constitution. The streets of medieval Bologna in 1342 presented a cacophony of medical options to the ailing citizen. On one corner, a university-trained physician in a long scarlet robe offered learned consultations, citing Galen and Avicenna while examining urine flasks. Nearby, a barber surgeon displayed bloodletting bowls and tooth extraction tools in his open-fronted shop. In the marketplace, an itinerant seller hawked bottles of miraculous elixir, claimed to cure everything from gout to melancholy. Meanwhile, in a modest home on a side street, an elderly woman prepared herbal remedies based on knowledge passed down through generations of women healers. This crowded medical marketplace reflected the complex hierarchy that characterized healthcare throughout medieval Europe. At the apex stood university-trained physicians, who claimed intellectual authority based on their Latin literacy and theoretical education. These practitioners, almost exclusively male and frequently from wealthy families, presented themselves as learned scholars rather than manual laborers. Their high status was visibly displayed through distinctive dress, long robes in rich colors, often fur-trimmed, and sometimes the square pileus cap that signified university education. The physician's professional identity centered on diagnosis and prescription rather than hands-on treatment. When treating a wealthy merchant with fever in 1380s Florence, the physician would examine the patient's urine, check pulse qualities, and ask detailed questions about diet and lifestyle. After determining which humors had become imbalanced, he would write prescriptions for appropriate remedies, but delegate their preparation to an apothecary and any physical interventions to a surgeon or barber surgeon. This delegation reflected not merely division of labor, but hierarchical separation. University physicians considered manual intervention beneath their dignity, frequently citing the Roman dictum, medicus non tangit. This separation allowed physicians to maintain their status as intellectual workers rather than craftsmen, a crucial social distinction in medieval society where manual labor carried lower prestige. Surgeons occupied the next tier in this hierarchy, with considerable internal stratification. Elite surgeons like Guy de Chauliac or Henry de Monville received specialized training, wrote scholarly treatises, and sometimes obtained university education, though rarely medical degrees. These practitioners performed complex operations including cataract removal, hernia repair, and amputation. They formed exclusive guilds in many cities, establishing standards and restricting entry to protect their economic interests. Below these elite surgeons stood the more numerous barber surgeons, who combined hair cutting and beard trimming with basic surgical procedures including bloodletting, tooth extraction, and lancing boils. Their shops, marked by the distinctive red and white striped pole, offered accessible health care to ordinary citizens. While lacking theoretical education, many barber surgeons possessed considerable practical skill gained through apprenticeship and experience. The relationship between these groups was characterized by constant tension and boundary disputes. In 1372, the surgeons of Paris secured a royal decree prohibiting barbers from practicing surgery beyond simple procedures, while university physicians repeatedly attempted to prevent surgeons from prescribing internal medicines. These conflicts were fundamentally economic, with each group attempting to secure exclusive rights to profitable procedures while restricting competitors. Apothecaries constituted another essential component of the medical marketplace. These practitioners prepared and sold medicines according to physicians' prescriptions, but also provided direct healthcare advice to customers who couldn't afford physician consultations. Their shops contained hundreds of ingredients, dried herbs hanging from rafters, minerals stored in labeled jars, exotic substances imported from distant lands, along with the equipment needed to compound them into usable medicines. The economic relationship between physicians and apothecaries created persistent conflicts of interest. Physicians often received kickbacks for directing patients to particular apothecaries, while some physicians owned partial interests in apothecary shops, allowing them to profit from their own prescriptions. These arrangements incentivized complex, expensive prescriptions containing numerous ingredients, even when simpler remedies might prove equally effective. Municipal authorities attempted to regulate these relationships. In 1258, the city of Florence established fixed prices for common medicines and prohibited physicians from owning apothecary shops. Similar regulations appeared across Europe, though enforcement remained inconsistent. Wealthy patients sometimes employed servants to purchase ingredients from multiple shops to ensure they weren't being overcharged through physician-apothecary collusion. Beyond these established practitioners operated a vast array of empirical healers with specific, limited expertise. Bone setters specialized in treating fractures and dislocations. Tooth drawers offered dental extractions in marketplace stalls. Itinerant cataract couchers traveled between towns removing cataracts with specialized needles. Herbalists, primarily women, gathered and prepared plant-based remedies. These practitioners learned through apprenticeship or family tradition rather than formal education, passing practical knowledge through generations. For rural communities with limited access to established practitioners, these empirics provided essential healthcare services. A village might be visited by a physician only during epidemics, if ever, making local healers the primary source of medical assistance. While lacking theoretical education, many empirics possessed effective treatments for common conditions based on generations of practical observation. The boundaries between legitimate practitioners and charlatans remained blurry throughout the medieval period. Without standardized licensing or consistent enforcement, unqualified individuals easily presented themselves as medical experts. Market squares across Europe featured traveling medicine sellers offering dramatic performances to attract crowds before selling supposedly miraculous remedies. These performances followed consistent patterns designed to build credibility and create urgency. The seller typically began by displaying impressive credentials, often forged documents purporting to show training in distant medical schools or service to nobility. Assistants planted in the crowd would provide testimonials about miraculous cures they had experienced. The seller would then demonstrate the product, perhaps drinking poison then taking the antidote, or revealing supposedly diseased organs removed from patients who had recovered after treatment. The remedies sold by these charlatans ranged from merely ineffective to actively dangerous. Common ingredients included colored water, cheap local herbs disguised as exotic substances, or alcohol-based preparations that provided temporary relief through intoxication rather than actual healing. More dangerous versions contained opium, antimony, or mercury compounds that produced dramatic effects mistaken for therapeutic action while causing significant harm. Municipal authorities attempted to control these practices through licensing requirements and prohibitions on unauthorized practitioners. In 1321, the City Council of Montpellier decreed that anyone selling medicines must have their products examined by university physicians before offering them to the public. Similar regulations appeared across Europe, though enforcement remained challenging, particularly for travelers who could simply move to another town when authorities became suspicious. The economic reality of medieval healthcare created a multi-tiered system where treatment quality depended heavily on the patient's wealth. For the nobility and rich merchants, illness meant summoning multiple practitioners to the home. A wealthy banker in 1400s Venice might consult several physicians simultaneously, comparing their opinions before selecting a treatment approach. These privileged patients received the most careful attention, with practitioners conscious that their reputation among elite clients determined their professional success. The urban middle classes, guild artisans, shopkeepers, and merchants of modest means typically visited practitioners at their shops or offices. They might consult a physician for serious illnesses while relying on barber surgeons or apothecaries for minor complaints. When hospitalized, they could afford private rooms and additional comforts, though not the extensive consultations available to the truly wealthy. For the urban poor and rural peasantry, options were severely limited. Day laborers earning barely subsistence wages couldn't afford physician consultations costing the equivalent of several days' pay. Instead, they relied on charitable institutions, folk healers, or self-treatment with common herbs. During serious illness, they might visit charitable hospitals where care focused more on spiritual comfort than medical intervention. The cost structure of medieval healthcare reveals these disparities clearly. A physician consultation in 14th century London typically cost between 6 pence and several shillings, depending on the practitioner's reputation and the complexity of the case. For context, a skilled craftsman might earn 6 pence daily, while an unskilled laborer earned half that amount. A single consultation could therefore cost a day's wages or more, making regular physician care inaccessible to ordinary workers. Surgical procedures commanded even higher fees. A cataract removal might cost the equivalent of 2 months' wages for a laborer, while complex operations like bladder stone removal could exceed a year's income. These high costs reflected not only the practitioner's skill, but the significant risk involved. Surgeons sometimes charged more for dangerous procedures to compensate for reputation damage if the patient died. Medicines represented another substantial expense, particularly those containing exotic ingredients. A compound preparation like theriac, containing dozens of ingredients including substances imported from Asia and Africa, might cost the equivalent of a week's wages for a small dose. Even simple medicines frequently cost more than ordinary people could afford, leading many to seek cheaper alternatives from local healers or attempt to gather medicinal plants themselves. Payment methods varied considerably across medieval Europe. Wealthy patients typically paid per consultation or treatment, sometimes negotiating fees in advance for complex procedures. The middle classes might arrange payment plans for expensive treatments, paying in installments over months. The poor often bartered goods or services when they couldn't pay cash. A farmer might provide food to a village healer, or a craftsman might offer products from his workshop in exchange for treatment. Some practitioners developed early versions of health insurance or prepayment plans. Guild members in northern Italian cities often paid regular contributions to a guild fund that covered medical expenses when needed. In 15th century Germany, some towns employed town physicians who received annual salaries to treat citizens, an early form of municipal health care. These arrangements remained limited to specific populations, however, leaving most people to pay directly for services or seek charitable care. Charitable institutions provided the primary safety net for those unable to afford private care. Monastic infirmaries, dating to early medieval times, offered care based on the Christian duty of mercy rather than payment. By the 12th century, specialized hospitals had emerged in many European cities, often funded by wealthy donors seeking spiritual merit through charitable works. These institutions, while providing essential services for the poor, focused primarily on spiritual care and basic nursing rather than sophisticated medical treatment. The Hospital of Santa Maria Nuova in Florence, founded in 1288, exemplified the more advanced charitable institutions. With separate wards for men and women, specialized areas for different conditions, and paid physicians who made regular rounds, it provided care substantially better than most medieval hospitals. Nevertheless, its approach remained fundamentally spiritual. Patients were required to confess their sins before admission, and religious services formed an essential part of daily routine. For most charitable hospitals, medical care remained secondary to spiritual ministry. Staff consisted primarily of religious brothers or sisters with limited medical training, supplemented by occasional visits from physicians or surgeons. Treatment focused on providing basic nursing care, clean beds, regular meals, and simple remedies, while emphasizing prayer, confession, and preparation for either recovery or good death. The physical conditions in these charitable institutions varied dramatically. Elite foundations like the Hôtel Dieu in Paris or the Hospital of the Holy Spirit in Rome maintained relatively clean facilities with individual beds for patients. More typical institutions suffered from overcrowding, with multiple patients sharing beds and minimal sanitation. During epidemic outbreaks, conditions deteriorated further as hospitals filled beyond capacity with little ability to isolate contagious patients. The medieval medical marketplace thus presented a complex landscape where quality of care depended heavily on social status and financial resources. The theoretical knowledge of university physicians, the practical skills of surgeons and empirics, and the spiritual care of monastic healers existed alongside the dangerous practices of charlatans and quacks. Patients navigated this system based on their means, their understanding of illness, and their access to different practitioner types. For ordinary people facing illness in medieval Europe, the experience often involved difficult choices between expensive treatments of questionable efficacy, cheaper alternatives from practitioners of uncertain qualification, or simply enduring suffering without professional intervention. The marketplace structure fundamentally favored practitioners over patients, with limited accountability for ineffective or harmful treatments and few protections against exploitation of the vulnerable. The irony of medieval medicine became most apparent when its practitioners found themselves on the receiving end of their own treatments. Guillaume de Baillou, a prominent 16th century French physician, discovered this harsh reality when he developed a high fever in 1580. Having prescribed bloodletting countless times for his patients, he now faced the prospect of experiencing it himself. His colleagues promptly removed nearly a pint of blood from his arm, weakening him significantly even as the fever persisted. Over the next 3 days, they performed 2 additional bleedings, applied blistering agents to his skin, and administered purgative herbs that caused violent diarrhea. In his personal diary, later published by his son, Belu recorded his doubts. "I wonder if I suffer more from the remedies than from the disease itself." This moment of clarity, rare in medieval medical writings, reveals the profound challenge faced by practitioners who became patients. Trained in a system that emphasized theory over results, they confronted the inadequacies of their art when experiencing its effects firsthand. Their personal accounts provide some of the most revealing insights into medieval medicine's limitations, as the veil of professional confidence dropped in the face of personal suffering. The occupational hazards facing medieval medical practitioners were substantial and varied. Contagion represented perhaps the most significant risk, particularly during epidemic outbreaks. Unlike modern healthcare workers with protective equipment and understanding of disease transmission, medieval practitioners worked without effective barriers against infection. During plague outbreaks, physicians examining buboes, surgeons lancing infected swellings, and apothecaries preparing remedies for the sick all faced direct exposure to Yersinia pestis. Many paid with their lives. Municipal records from plague-stricken cities tell a grim story of medical casualties. In Milan during the 1348 Black Death outbreak, 17 of the city's 20 contracted physicians died within the first 3 months. Florence lost nearly 70% of its medical practitioners during the same epidemic. These deaths created desperate shortages of trained personnel just when they were most needed, forcing cities to offer extraordinary salaries and privileges to attract replacement practitioners from unaffected regions. The psychological impact of working during epidemics appears repeatedly in physicians' personal writings. John of Burgundy, who survived the initial Black Death outbreak, described his terror when treating plague victims. "Each day I wonder if this patient will be my doom, if this examination will be my last." He developed elaborate protective rituals, including holding aromatic substances in his mouth while examining patients and washing his hands in vinegar afterward. While these measures provided little actual protection, they offered psychological comfort against overwhelming anxiety. Contagion risks extended beyond dramatic epidemics to include common infectious diseases. Surgeons regularly contracted wound infections from patients, sometimes developing life-threatening sepsis from seemingly minor cuts or abrasions acquired during procedures. Barber surgeons treating syphilis patients often contracted the disease themselves through contact with infectious lesions. Without understanding of germ theory or effective barriers, cross-infection between practitioner and patient remained a constant occupational hazard. Toxic exposure constituted another significant risk for medieval medical professionals. Apothecaries regularly handled dangerous substances including mercury, arsenic, lead compounds, and various plant toxins. Preparation methods often involved grinding these materials into fine powders that could be easily inhaled or absorbed through skin. Chronic low-level exposure produced cumulative damage to the nervous system, kidneys, and liver, resulting in tremors, cognitive impairment, and premature death. The effects of this occupational exposure appear in guild records documenting the typically short careers of apothecary apprentices handling the most toxic substances. In Venice, apprentices assigned to prepare mercury-based medications rarely survived more than 7 years in the profession, developing characteristic tremors and personality changes before succumbing to kidney failure or neurological collapse. Despite recognizing these patterns, the trade continued using these substances, considering the risks an unavoidable aspect of the profession. Surgeons faced more immediate physical dangers from their patients. When treating individuals suffering from head injuries, psychosis, or alcohol withdrawal, they risked violent attacks. Amputation patients, experiencing unbearable pain without adequate anesthesia, sometimes struck out at practitioners in desperation. Surgical texts included specific advice on restraining patients and positioning assistance to protect the surgeon from unexpected movements or deliberate attacks. Henry de Monville, an influential 14th century French surgeon, documented being stabbed by a delirious patient during a procedure to remove an arrow. The patient, awakening from an alcohol-induced stupor during the operation, grabbed a nearby surgical knife and plunged it into Mondeville's thigh, narrowly missing the femoral artery. This experience prompted Monville to develop improved restraint techniques and to recommend surgeons position their instruments beyond patients' reach during procedures. Beyond these dramatic incidents, medieval practitioners suffered the chronic physical toll of their professions. Surgeons developed spinal deformities from bending over patients in poor lighting conditions, while eye strain from detailed work in inadequate light caused premature vision loss. Barber surgeons suffered skin damage from constant exposure to water and irritating substances used for cleaning instruments. These occupational ailments frequently forced practitioners into early retirement or limited practice. When faced with their own mortality or serious illness, medical practitioners often recorded insights that differed markedly from their professional writings. These personal accounts revealed doubts, fears, and reconsiderations rarely expressed in formal medical texts. The contrast between public confidence and private uncertainty provides a revealing window into the medieval medical mind confronting its own limitations. Guy de Chauliac, the preeminent surgeon of the 14th century, contracted plague during the Black Death while serving as papal physician in Avignon. In his influential surgical text, he confidently prescribed specific treatments for plague, including bloodletting, purging, and various herbal preparations. Yet in his personal account of his own illness, he admitted applying none of these remedies to himself, instead focusing on rest and supportive care. He survived, later acknowledging that many standard treatments seem to hasten death rather than prevent it, an observation he included in later editions of his work, but never developed into a systematic critique of established practice. Personal illness sometimes prompted significant reconsiderations of medical theory. John of Gaddesden, author of the influential Rosa Anglica medical text, developed severe arthritis in his later years. Having previously recommended aggressive purging and specialized diets for such conditions, he found these treatments worsened his symptoms when applied to himself. His private letters describe experimenting with warm baths and gentle massage, approaches not found in his formal writings, but apparently more effective for his personal comfort. This gap between public recommendation and private practice suggests a pragmatism rarely acknowledged in official medical discourse. The deathbed confessions of medieval practitioners provide particularly poignant insights into their retrospective assessment of their life's work. Arnau de Villanova, the renowned Catalan physician who served kings and popes in the early 14th century, reportedly gathered his students around his deathbed to declare, "I have often acted more from custom than conviction, prescribed remedies whose effects I doubted because patients expected them, and claimed certainty where I felt only confusion. Remember that medicine is an art of probability, not certainty." While possibly apocryphal, this statement captures a sentiment expressed in various forms in multiple practitioners' final reflections. More concrete evidence comes from physicians' wills, which sometimes included provisions suggesting skepticism about their profession's efficacy. Several 15th century Italian physicians explicitly prohibited bloodletting, purging, or specific medications in the treatment of their final illnesses, suggesting they recognized these interventions might hasten death rather than prevent it. Others left funds for masses and prayers rather than medical care, perhaps indicating greater faith in spiritual intervention than in the treatments they had provided throughout their careers. The psychological burden of practicing medieval medicine created distinctive stresses rarely acknowledged in formal medical literature. Practitioners faced constant ethical dilemmas when administering painful treatments with uncertain benefits. They witnessed suffering caused by their interventions, sometimes followed by patient death despite or because of their efforts. This combination of responsibility, uncertainty, and witnessed suffering created what modern psychology would recognize as conditions for significant moral injury and trauma. Evidence of this psychological toll appears in various forms throughout medieval medical writings. some practitioners developed elaborate justification systems, emphasizing that patient suffering during treatment represented necessary steps toward potential healing. Others adopted fatalistic perspectives, attributing outcomes to divine will rather than medical intervention, a perspective that reduced personal responsibility but potentially undermined the rationale for their profession entirely. Alcohol use appears frequently in accounts of medical practitioners, suggesting self-medication for psychological distress. Municipal records occasionally mention physicians or surgeons known for excessive drinking, while medical guilds sometimes implemented rules against practicing while intoxicated. Without modern concepts of professional burnout or trauma response, practitioners had few healthy outlets for processing the emotional impact of their work. Religious frameworks provided the primary psychological support for many practitioners. By conceptualizing medicine as a divine calling and patient outcomes as ultimately determined by God, they could maintain purpose while managing expectations. Medical texts frequently opened with religious invocations and reminded practitioners to recognize divine authority over life and death. This perspective offered some protection against the full psychological impact of practicing treatments that frequently failed or caused additional suffering. The limitations of medieval medicine became particularly apparent when practitioners treated colleagues. Medical professionals observing treatments applied to their peers recognized familiar interventions from an external perspective, sometimes prompting rare moments of systematic doubt. Accounts of physicians treating other physicians occasionally include discussions about treatment efficacy that appear nowhere in their general medical writings, suggesting a different standard of critical evaluation when the patient shared their knowledge base. Bernard de Gordon, teaching at Montpellier in the early 14th century, recorded treating a colleague for severe pneumonia. After standard interventions, including bloodletting and purgatives, visibly worsened his colleague's condition, Gordon abandoned traditional approaches in favor of simple supportive care, maintaining hydration, providing easily digestible food, and ensuring rest. The patient recovered, prompting Gordon to question conventional treatments in his private notes while continuing to teach them to students. This compartmentalization, private doubt alongside public adherence to tradition, characterized many practitioners' response to evidence contradicting established theory. The gap between theoretical knowledge and practical experience created cognitive dissonance for many practitioners. University-trained physicians possessed elaborate explanatory frameworks derived from ancient authorities, but limited effective treatments. When these physicians became patients themselves, the inadequacy of their theoretical knowledge became painfully apparent. Some responded by developing increasingly complex explanations for treatment failures, while others began cautiously incorporating empirical observations into their approach. By the late medieval period, this tension had created the beginnings of a methodological shift. Practitioners including Gentile de Foligno and Jacopo de Forli began emphasizing observation alongside theory, particularly after experiencing illness themselves. Their writings include careful descriptions of symptoms and treatment responses based on personal experience, representing early steps toward the empirical approach that would eventually transform medicine. The experience of personal mortality ultimately forced medieval practitioners to confront the same uncertainties and fears as their patients. Despite their specialized knowledge and social status, they remained vulnerable to the same diseases, subjected to the same painful treatments, and faced the same inevitable end. This shared humanity occasionally broke through the professional distance maintained in formal medical practice, creating moments of genuine connection and compassion. As medieval medicine gradually evolved toward the Renaissance and early modern approaches, these personal experiences of practitioners contributed to important reconsiderations of traditional methods. The accumulated observations of physicians who had experienced their own treatments, witnessed colleagues suffering through standard interventions, and recorded their doubts provided essential foundations for the medical reforms that would eventually emerge. The medieval medical practitioner's confrontation with mortality thus reveals both the profound limitations of pre-modern healthcare and the essential humanity of those who practiced it. Behind the formal theories, specialized terminology, and social prestige lay individuals struggling with the same fundamental challenges as their patients: the experience of suffering, the fear of death, and the hope for relief or cure. In this shared vulnerability, perhaps more than in their treatments or theories, medieval practitioners achieved their most meaningful connection to those they sought to heal.